Hello. Can you hear me? Hi, Dr. Joseph. How are you?
I am excellent. How are you?
Very good. This is Nidal. Thank you for coming today to give us this talk.
Absolutely.
Hopefully, soon we'll be starting. Hazar she should be joining us to. Uh,
I'm here, Dr. Nidal. I just
Oh.
was on mute, waiting for
Oh.
everybody to show up.
yeah. Hi. How are you?
Hi. Hi, Dr. Joseph.
Hi, Hazar. I haven't seen you in a while.
Hey, yeah, I know. I've been busy with STEM stuff.
It keeps you out of trouble.
That it does. It really does. So how about you guys? We wait another 2 more minutes or maybe 5. Should we do 5 minutes to make sure everybody who's able to join us joins? Or
Yeah,
would you like to start?
I think so. Usually they run behind. So.
Well, the Arab time is always a little later, right? Isn't that how it
Yeah.
works?
Unfortunately, yes.
And do you want to give me sharing screen access so I can?
Hi, Dr. Joseph. Yeah, I can do that. Do you mind that we are recording the session?
Not at all.
All righty. I'll give you the access.
Excellent.
Can you try and share something, please?
Yeah, it's still host disabled.
Dr. Joseph, how do you say your Pittsburgh, Pennsylvania hospital? Is it Allegheny?
Yeah, Allegheny General in Pittsburgh.
Okay.
All right. I think I got it.
All right.
Are you able to see this?
Yes.
Excellent. Well, you give me the cue when to start.
I was thinking, Danny, if you want to record and start recording now, in case when you want to share it, or do you usually share the recording with the members?
It depends if they ask for it.
I see.
But like it's the session is made as recorded session.
Oh, I see. Okay.
I can stop recording and then record, but it says like it's made as a recording session.
No problem.
So are most of the members from Chicago or just all over the country?
Oh, we have members in all over town, all over the United States and also international, but mostly from the United States. We have about 700 plus members.
Oh, terrific.
Okay, well, we are going to start. Are you okay with that, Dr. Joseph?
Sure. Whenever you tell me, whenever you guys are ready.
Okay. Okay, we have about 10 people, I think, or maybe less. Okay. I'm going to go ahead and introduce Dr. Joseph. Dr. Joseph Prajakyan is I mean, there's no words that can give this man justice. Dr. Joseph is a good friend of mine. I met him through a SAMS project, big mission that he led last May to Lebanon. He's a distinguished board certified or maxillofacial surgeon, has studied, done his education at Tufts and Drexel College of Medicine for his medical degree, and then done 6 years surgical training, completed at Allegheny General Hospital at Pittsburgh, Pennsylvania. He now works at the Cleveland Clinic, and he's a visiting professor at Tufts University. Your expertise, Dr. Joseph's expertise, will be very clear today through the conversation and us listening to you. But my favorite part is your humanitarian work and your human touch to everybody who meets you, everybody who's ever been your patient or your colleague. We all look up to you and we all admire your work. And I'm thrilled that SAMS earned a member recently, and that you are sharing your expertise with our members. And please, I'm going to give you the mic.
Well, Dr. Hazar, thank you. That was a very beautiful introduction. I'm humbled to be part of SAMS and to be able to have the ability to contribute. You know, I was born in Syria. I was raised in Lebanon. This is very close and dear to me, as to all of you. And there's nothing more beautiful is to be able to make an impact than to give back to your own people. And I don't think I've seen an organization like SAMS, and I've done plenty of mission works, probably over a dozen across the Central South America. But SAMS has captured my heart, and I've been part of it over the past 3 years. And we've tried to elevate and focus on a lot of the facial reconstruction. And we've done a couple of missions already. We helped organize a mission for Jordan that Hazar led, and we're here. We're here. I was asked to do a little talk about some advanced facial reconstruction, and I thought, what a beautiful way to introduce some of the work that we have done with SAMS, and also introduce some of the advanced techniques and technologies into helping us in the humanitarian mission. So the title of this talk is, the role of virtual reality in facial reconstructive surgery and its use in humanitarian mission. And I'm proud to say that SAMS was probably, if not the first NGO to participate and be part of our advanced technology into humanitarian mission that we did in Lebanon, and we also participated in Jordan of last year as well. So that said, I thought we will introduce the overall kind of an outline. I'll talk a little bit about the scope of our surgery, of our specialty, because we get asked that question tremendously. So I thought it'd be good to kind of give a preview of what we do as a role, what's our background and training is. We'll talk about some innovation in facial reconstruction and its role with SAMS and some of the work that we have done. Some background information, but I think Hazar did a beautiful intro. I'm part of the Cleveland Clinic staff. I teach at Tufts. I'm a visiting professor there. We have our own private practice here in Cleveland, Ohio, soon to be transitioning to Boston, faculty at Case. So we have a lot of innovative components to some of these things. But one thing that I always like to do, and when any of the talks that we give, is to really engage the audience. So hopefully everybody will be able to pull up a cell phone at least in the US, text Krajakian to 37607. And that will be prompting you to answer some questions that I will pose. If you miss this, you'll have the opportunity to do it again. In the US, you can text Krajakian to 37607. If you're international, you can go to that website, polev.com/Krajakian, or scan the QR code. So with that, we'll start, and we'll give a scope of the specialty itself. So an oral maxillofacial surgeon in the United States usually have a underlying dental degree. So you get your bachelor's, you get your dental degree, which is basically 4 years. Then you have the option of, doing advanced training in oral maxillofacial surgery, which includes going to medical school. We do 2 years in medical school, the 3rd and the 4th year clinical. We have to take all our boards. And then we do additional surgical training and fellowship. And you have different focus elements, but we rotate under, general surgery for 2 years, which will allow us and give us exposure to ENT, plastic, neurosurgery, urology, trauma, ENT, vascular, colorectal, whole gamut of elements of specialties, which I think really molds us to become more of a comprehensive and understand how does the body integrate to the head and neck, and give us the ability to manage patients a little bit more cohesively and understand really all the specialties. So with that, one of the elements that we do is facial reconstructive surgery. These are patients that are born with facial deformities. So they go through braces, and we do all these traditional analysis by taking a lateral facial profile. We do angle measurements on a whole host of things. I'm showing you really the traditional way of how we have done things for decades. Then we were able to perform surgery for a period of 3 to 4 hours. We're able to advance the upper jaw, advance the lower jaw, align things. And this is referred to as a more of an oral and reconstructive or orthognathic surgery, upper lower jaw advancement. So we can take somebody, from how he was from the left side to when they're completely grown and surgery is performed, and we can bring them to this. So, and this is a small animation that kind of shows what that procedure entails. It's, taking a discrepancy. This is a person that has a completely lower jaw discrepancy where it's set back. So it's retrognathic, small mandible. Patient goes through the braces. We're able to advance the lower jaw forward while maintaining the nerve structure and integrity, which changes their profile. That's also a surgery that we do, believe it or not, for obstructive sleep apnea, for opening the airway. So patient will go to braces afterwards at some point, and we'll talk about how we're integrating that into our SAMS mission in Jordan and in Lebanon. But that's kind of the before and the after from an animation standpoint. The same applies for obstructive sleep apnea. So this is a patient that has an apnea-hypopnea index of 105, and he's in his mid-40s. So, as you know, obstructive sleep apnea has stages. Stage 1 being 0 to 5, 5 to 15 is mild, 15 to 30 is moderate. Anything over 30 is considered more in the severe category. He's a truck driver, so you can imagine his ability to stay awake, his ability to maintain concentration is significantly compromised. And, he cannot tolerate the CPAP or the BiPAP. So the only option that we had for them is to be able to do what's referred to as maxillomandibular genio advancement. So we bring in the upper airway, the lower airway, and we also bring in the genioglossus by doing the advancement genioplasty. And we put all our plates. And as a result, we're able to open the patient's airway from here being significantly narrowed to what we have here. And that's almost quadruple the amount. And when we look at it from a volumetric standpoint, it is significant because the airway is in 3-dimensional. So that's a big component. So bring this gentleman's AHI from 105, which is in the significant severe, to almost to 5, which falls into the normal. So that is a significant component for obstructive sleep apnea and the role of maxillofacial surgeons in this. So this is the before and a year after. Not much of a change in their profile or their weight changes, but it significantly opens an airway. And as a result, they live a little bit longer and they'll have improved quality of life. Cardiopulmonary status is improved as well.
Dr. Ammar, could you please mute? Thank you.
The other component that we deal with a lot is the temporomandibular joint. That's a very sensitive topic for a lot of us because most of us really don't know how to manage it or how to address it. So temporomandibular joint, it's the jaw joint that most of us are familiar with. It affects the ability to function, jaw pain, the headaches, the migraines, the atypical facial pain component, the neck pain. So there's a whole host of things, in addition to tumors that develop on these things, overgrowth, osteoarthritis that causes fusion. And these things get significantly overlooked by the medical community and even in the dental community, because there are not many surgeons across the US that perform these kinds of surgeries. There's probably about 100, I would say 150 out of the 6,000 maxillofacial surgeons that address these. And about 600 to 700 cases of these that are done in the US. That's in the US. When we were in Lebanon, there wasn't anybody in the country that's performing these surgeries. And we were fortunate enough that we were able to, through our partnership and collaboration with Biomet, which is one of our manufacturing company for head and neck CMF, we're able to donate about 8 joints that we were able to do several of them in Lebanon. And we had some really good success. And I'll show you some of these later on. And it will involve no different than having somebody who has a knee arthritis that would need a knee replacement, or an osteoarthritis of the hip that requires a hip replacement. And this is going to require temporomandibular joint replacement. These are very technical and very complex surgeries. Usually each side will take about 3 to 4 hours. And if you're doing both sides, it's a kind of a whole day case. And end up functioning like this. Quality of life is significantly improved. But that's just wanted to give you scope. One of the other things that we do also and manage is, facial trauma. It's one of the things that we are, we collaborate with our ENT colleagues and plastic colleagues and neurosurgery colleagues, but we're able to handle, for the most part, full fan facial complex, and sometimes involves having what's referred to as a coronal flap, where we deglove and be able to access the frontal bone. And here with our neurosurgical colleagues, we're able to place all the plates and the screws to give continuity back. One of the other things that we deal with as well is cancer, benign or malignant. In this case, this patient had a significant radiolucency of the entire mandible. We were able to resect it. We go to the hip, we take some cortical cancellous bone. In this case, we took a rib that we were able to split it on the superior portion, inferior portion, kind of sandwich the implant, sandwich all the graft in there. We take some of the stem cells from the hip, and we were able to do, believe it or not, some of these cases in Lebanon. And we will talk about how we're able to bring these in there. And this is kind of the end result of what we are able to provide these patients. And this was a benign tumor. And this is kind of the before and a year after. So the aspect what I wanted to focus on is to give you a scope of the surgical interventions that we do. But what I wanted to take you is to a journey of innovation and how the innovation today and the impact that it had into the scope of head and neck, but also take it even further. So one of the first questions that I'm going to ask, and hopefully you'll be able to answer. And again, you can join by texting the information 37607, text Krajakian, and you will be asked to answer A, B, and C. And as soon as you answer—
Dr. Joseph, I'm going to write it in the chat so people can pick that number up.
Perfect. And it's also on the screen as well. 37607, text Krajakian, and you'll be able to answer. And as soon as you answer, we'll be able to see the response. So this makes it more of a interactive because I'm going to ask really some more questions later on as we move forward. So I'll wait a couple of seconds and get a better feel for what you guys think and your responses, and then we'll take it from there. So, virtual VR, meaning the virtual reality, and it's the headset. Most of it, you've seen it for gaming, probably of our kids or, younger sister and siblings will probably have these and played with them. But most of them are for gaming. And a lot of us professionals, like I've never played one of these VR games, but I came introduced to this about 6 or 7 years ago into the head and neck reconstruction. And at no point over the past 5 years, we've done any sort of a complex surgery without it. So I will say, 70% of the audience has not, and we have 14 people now, have not really done this. And those who had, about half, seems to have done it into the gaming element. So then I'll ask the next question. How knowledgeable are you about virtual reality? I think a lot of us are pretty aware of AI, the artificial intelligence that really seems to be dominating a lot of the conversation, and its pluses and minuses. We'll talk about how we're integrating that into what we do. But I wanted to get a better feel for the virtual reality integration. And I think that's kind of what we get whenever we get these conversations about significant amount, usually 2/3, which matches what we have here, really don't know much about it. They know of it, but they don't know really how to integrate it into medicine or even into surgery. So I'll wait a second and see if that number is going to change. And I think it's consistent. So that's great. That's really what the trend seems to be the case. So the traditional way how we've managed these cases, as you probably have known in any of the locations that we've done surgeries, is really
Dr. Wasim, could you please excuse me? Thank you. Sorry about that.
So one of the things we've always seen whenever we go to whenever we look at any imaging, you look at it from an axial, coronal, and you're looking at a 2D picture. If you're lucky, significant amount of your institution will give you ability to do 3D rendering. Sometimes you have to ask for it, like at the Cleveland Clinic, I have to ask for it, and usually it takes about 24 hours for me to get the response. And they usually give it to me, and I get something similar to what's really on your screen. But, I think we can do better. I think significant amount has ability to improve. So one of the real questions I'm going to ask, and this doesn't apply really to the facial skeleton, but if you're looking at a CT scan, it could be a chest, could be an abdomen. Are you truly able to visualize the 3D anatomy? And I don't know the answer to that. I'll tell you what, we struggled a lot when you have a panfacial trauma, when you have a trauma that is so complex, or you're looking at a tumor, you're looking at a cyst. It is so difficult for me to be able to look at everything in 3 dimensions and visualize it. And even worse, how do you explain that to a patient? Yes, you have a fracture of your cheekbone. Yes, you have a fracture of the frontal bone. You have the fracture of the mandible. And you draw it on the 2-dimensional or the 3-dimensional picture that the radiology department might give you. But truly, I think it's more complicated than we think. I think our radiology colleagues might be able to be better at it than we are, but that's a struggle, right? And we base decisions of managing and treating patients based on this data. So can we do better? I think we can. So my next question that's going to, and I think you're going to know the answer to this one as we move on, but do you feel there's any benefits to the role of virtual reality in medical education, medical training? So I want to base it on not more than what we just spoke, but do you feel that there is a role in it? Is there a role for me to put a headset on and be immersed into the anatomy of the patient and get a better feel for it? I think a lot of you answer that is yes. And you'll see it. This whole presentation is focused on it. So I think it'll be interesting to see there is time for change, and the change is now. So we're able to take a 2D CT data, could be a CTA, could be a CT with soft tissue or hard tissue, where I put the headset on and I am immersed completely into the 3D skeleton. I can look where my veins are. I can look where my arteries are. I can look at where my anatomy is. But this is great. But there's another level to it. Being immersed is wonderful, right? I can see things in 3D. But when you're able to manipulate it, that takes it to another dimension. And that's what we were able to do about 2 years ago. Take this data and play with it. And I'll show you what that means. So virtual reality, augmented reality, and mixed reality. I think it's important, and most of you probably know the definitions for these, but it's important for me to highlight it as we move forward. And I'll tell you where the innovation seems to be headed. So virtual reality, you are completely immersed. You put the headset on, you do not see the real world. You're in this immersed world, and you're able to see the CT data, the MRI data, and manipulate it, take measurements, remove a layer, make the mandible transparent, make the skull transparent. That's virtual. Augmented is similar if you're driving one of the new cars and the windshield is going to tell your speedometer. So it's static data that's presented to you in front of you while you're seeing your real world. That's augmented reality. But you're not interacting with it. It's just displaying data. So it could be, for example, the Meta released one of these Ray-Ban glasses, and it's augmented. So you can be running and you're able to make a phone call or ask information. It's giving you static data. You cannot interact with it, right? Mixed reality is this new Apple Vision Pro that came into the place, or the HoloLens that Microsoft had several years back, almost 8 years now, and HoloLens 2. And I'll show you how we're integrating that. That's where you have the mixture of both, or called X reality or mixed reality. So you're immersed, but I can do finger gestures and I can interact with it. I can zoom in, I can shrink, I can rotate, I can take measurements, and I can overlay CT data and look at everything more immersely and interactively. That technology is becoming better and better and better. We're not completely there yet, at least from my experience with regard to surgery. But I'll show you where we're heading. And I think with the Apple Vision Pro that was released, earlier in the past several months, I think there's a lot of innovation coming in the pipeline. And there's a lot of investments that's going into this. But that's kind of the definition between. So we'll start with basics, right? I'll show you what we're doing in head and neck. So since I'm a dentist in training, and an MD and a surgeon, one of the things that we do a lot is dental implants. So here, we're able to proceed in taking measurements that I need. I'm able to assess where my nerve is in the mandible. I can measure my dimensions from anterior to posterior, medial to lateral. I can look where my sinuses are. And for our dental colleagues, they'll appreciate that more, or even our ENT colleagues. But here, if you realize, I'm able to take a burr, I'm able to take a drill, and I can drill bone. I can simulate surgery. And not only that, it gives me tactile, and it gives me the noise. So as I am immersing myself, I'm able to surgically place. I am rehearsing my surgery. And this is a simple dental implant, right? The dental implant, if it's done wrong, if it's done at a wrong angle, you take a chance and a risk to get a person permanently numb. So that's important. Here, I'm able to take a tooth out in virtual space, and I can practice drilling. So I can tell the patient, yes, I'm able to take a tooth out and put in an implant at the same time because your structure and your anatomy allows me to do so. And I'm able to place the bone and everything else that I want. I can even take my 3D rendered crowns and place it there. So now we're no longer just looking at being immersed. But I can take a very complicated case that today in the technology outside of this takes me about an hour, 20 minutes to plan a case. Here, I'm able to plan a case in no time. You just saw it took me basically a minute, and I'm able to predict. And from this, I can 3D print everything that I want. So that is a huge component in the dental field. Here's an example where a patient has a benign tumor in the mandible. So we took the CT data. I identified where my tumor is in this patient who's edentulous. We did an incisional biopsy, so we know what it is. I can measure it, so I can know its dimension in 3D. And I don't need an engineer for this. You as a surgeon can do this as a provider, but I do see tremendous value in patient education. So patient is able to understand what their anatomy is. They can understand their pathology. They can understand the true definition of what their surgeries entails and the risk. In this case, we're sacrificing the nerve. And now I can go in, put titanium plates in there. Can put, obviously in the mandible, you always need to have two so that you're not torquing anything. And that's not really the focus of this conversation, but it gives you an idea what we're obtaining. I can identify what length screws that I need, and I can have all this planned out before you walk into the operating. I know what plates I need. If I really want, I can even 3D print the mandible, and I can have my plate bend pre-op. So I have ability to manipulate all this and be immersed in it. The other thing that I can do is if I needed to do, for example, in this case, we needed to add bone from the hip. So I can three-dimensionally volumetrically measure my defect, and I can go to the hip and augment and assess how much bone I need from the hip and build to it. So that is a huge component that allows me to do things that in ways that was not even possible. So, but here's another example where, that's the same one. So this is another example. I can take the entire mandible of a patient. I can see the motion of it, right? I can, and for us as dentists, that's critical because I can look at how the teeth align, and we can even analyze contact points. But I can disarticulate a mandible. I can disarticulate a maxilla. I can disarticulate, for orthopedic colleagues, the hip. And you can look and measure things in ways that other means were never even possible. Here's an example where we have a patient who was 22 years old with hit in a motor vehicle accident. So this is the fracture. So we took the CT data, put it into our VR platform. I'm able to show the patient, where their fractures are, or the family at least, and I can really position everything in ideal location. Now, what we even can do even more, if one side is fractured and the other one is not, if we have old CT data of that patient, I can automatically have the software realign how everything is supposed to be. I can 3D print custom plates for the patient that puts everything back where it's supposed to be. Significant amount of orthopedic or facial trauma is requiring having to bend the plates and mold them into the right place. We can do all of this at the time of the pre-OR, which is tremendous value to our cases. Adds significantly much more accuracy in being able to manipulate and achieve the desired outcome. The other thing that's also valuable is the ability to reduce OR time, reducing risk for anesthesia, cut down costs for the OR. And there's a tremendous benefit, and this is in the pipeline, and it's working. So this is the patient. It's a hypothetical patient where it has a squamous cell carcinoma, cancer of the mandible. And in this case, it requires removal with healthy margins. We're taking half this lady's mandible. But one of the surgeries that we do for head and neck cancer is we do a free flap. So I got to go to the leg, take a piece of bone from the leg, and at the same time, take also some muscle, some vasculature, and reconnect it. So here we have a CT of the face, and at the same time, I have a CT of the leg. So I'm able to perform my resection in VR. Patient can see this beforehand and they can understand. Now I'm going to attempt to reconstruct it, and the curvature of the mandible is never easy for those of us that do these reconstruction. To gain that contour back is challenging. So here I'm able to take part of the leg. I can determine what part of the leg is going to give me the optimal position. I can rotate and manipulate all of these. And me as a surgeon are doing these. I don't need an engineer. I don't need anybody. I am doing all of this freehand, independent of anything. And even now, we're able to put dental implants into the leg before we take it into the face, which is a tremendous. So we call that jaw in a day, from a cancer to an outcome of a complete transition, beautifully, where a patient is able to get the implants and their teeth within the same day. From morning to the afternoon, that's their outcome. We can even have their denture or their prosthesis or their fake teeth made before we even walk to the operating room. We know the implant sizes, the location, all the stuff can be put in the leg before it's taken to the face. You can imagine how that plays into the patient outcome, quality of life, and survivability. This is a patient that's a facial deformity, and here's how we do our consult. So when I met, this patient had a complete condylar resorption. She has no TMJ joint. We're able to identify, and this is how we do the consult. I'm able to take the CT scan. I'm able to identify all these issues with the patient and their family. I'm able to do all my measurements, and in facial reconstruction and these orthognathic-based surgeries, we rely on a lot on measurements, on angles, and so these are the things that we attempt to establish, and we follow at least what's considered normal, and normal is a very subjective term, but it gives us an idea what is considered facial harmony, cosmetically appealing, and it changes from culture to culture, but we have some data and measurements that we rely on, and we recognize the discrepancies. And here we're doing all the measurements, and now I'm able to do the surgery virtually. So I'm able to do a virtual osteotomy, cutting the bone, positioning everything that I want. So this is my advancement, genioplasty. Next is going to be my mandible. I'm able to remove a section of the maxilla. And believe it or not, we actually did some of these things in Lebanon. I'm able to perform and plan a very complex case that usually takes hours in a matter of minutes. I can identify where my nerve position is going to be to avoid certain key elements and key nerves and key structures, with the attempt and the objective at the end to give them complete facial harmony and a full reconstruction for them to improve their quality of life. This is not considered cosmetic. Cosmetic is an added benefit, but it's a very reconstructive, and medical insurance pays for it because it affects the patient overall, relationship, social, the social impact. Especially in our culture, they're going to look at it. They're going to say, well, you're not very appealing. You're not considered very attractive. You have over-gum issues. So, and there's functional benefits. So there's a whole harmonious element to doing and performing these surgeries. And here we're able to place the plates. We're able to identify everything. And as an end result, we're able to 3D print guides that tells me where I need to do the cuts, and how to perform my surgeries. And all this is done before we even enter our host countries. And that's something that we were able to do. And this is the end result, right? We're able to put, both TMJ joint implants. We're able to do our Lefort osteotomy. We're able to do the mandible, and we're able to bring the chin forward. And the end result is somebody that from the left to what's considered the right, and that's a 3-month post-op. And all the stuff, for the most part, is done intra-orally with very small incision on the face. So from the left to the right, 3 months post-op. So my next question that I'm going to pose, and again, you can send text message to 37607 Krijakian. Do you feel complex facial surgeries other than cleft lip and palate can be performed on medical surgical mission that are about a week or 2 weeks long? The answer to that about a year ago was probably not. And I'll tell you, so it's a 50-50. That's interesting. That's good. Seems to be the response. But if we don't do it, who's going to? That's where the challenge is. So Operation Smile, Smile Train, all these organizations that we work with, they do the cleft lip and the cleft palate, and that is a blessing, and it's wonderful that it's done. But then there's another level to it. You know, the cleft lip is going to have significant amount from a scarring where the maxilla is not going to be developed correctly. So you're going to have aharmony or asymmetry. And these things are going to lead to facial deformities later. So I do feel that it can, and we've done it. And we've done it in 3 missions, and we're proposing a concept, a change, and a shift. And SAMS was the first and only organization that I'm aware of worldwide that have attempted to do this, and we were successful. So let me walk you through how we did it. We screened, Hazar was instrumental in helping me this, but so we developed a database and questionnaire to patients. We send a WhatsApp form that's a HIPAA compliant, and we had about 300 cases where patients felt they need these surgeries. Her and I sat down for days and hours, and we identified every single patient where we felt these surgeries can be performed safely. Some we couldn't. Identified each one, and we determined what data we need. Most of the time, it was the data basically getting a CT scan in a certain position with certain parameters that allows us to do the VR. We identified the CT. We were able to perform the surgeries in VR prior of us, about a month, 6 weeks prior to us getting into the host country. We did all the planning. We 3D printed whatever we needed. We determined the spacing, the measurement, the rehearsal. We have all the files, everything we need. We completed the finalization of the plan through some engineer who ultimately does the detailed work. We spent 5 minutes, but we do the planning all in the 3-dimensional space. We give that data to an engineer, and there's several companies. There's actually one leading company that we partner with out of Chicago. They're called Immersive Touch. They're one of the first and pioneers with regarding using virtual reality and now augmented reality into the head and neck space, and also in orthopedics, neurosurgery, and so forth. So we have all that data accumulated. We walked into Lebanon with a bunch of 3D printed skulls, mostly mandibles to cut down the cost, or maxilla, and guide that tells us where we need to do our surgeries and manipulate things. We performed the surgeries, and intraoperatively in Lebanon, we had access to a VR computer and a standby engineers in Chicago if we ever needed anything, and we were able to manipulate and perform exactly what we intended to do. And I'll show you some of these cases. We do post-op CT scans, and then we compare. We take the post-op CT, did we execute what we were intended in VR? And we can have the software overlay what was what was virtually planned, and what was actually done. And are we in alignment? And for the most part, as long as within 5-10%, that's considered, in my mind, acceptable. And then we obtained any post-op, and all the patients we've operated on in Lebanon communicate with me directly to their WhatsApp. And the beauty of SAMS that we have on-ground personnel to help us do and manage anything that's needed. And we jump on it directly. We had one patient in Lebanon that had a post-op complication with wound dehiscence that we were able to address. And there was one that had a wound open 8 months later, and we were able to make arrangement last week to get the plate removed, and everything is looking great. So we're able, not saying that every case is going to be perfect, absolutely not, but we have the means to integrate some of these things and really give an outcome that otherwise we were not able to do. So this is a patient from 2 years ago in Lebanon that we met. It was in his mid-30s. It is a panoramic X-ray where you can see and identify in the middle picture on the top his tumor. It was benign. So we were able to do the virtual surgery for him on a computer before we went and got to Lebanon. We 3D printed a mandible. As a matter of fact, we 3D printed this in Lebanon for $30. It would have cost us a lot more in the US. And we had a plate that we 3D bended. We did his resection, and we finished the surgery for him on phase 1, which is remove the tumor, have him function, let the wounds heal, and then come back a year later and reconstruct. And that's what we did. A year later came in, and we look on the upper left, we see where the plate looked and everything else. And for him, which was unique, that we needed to build a joint to it because his upper condylar head was going to be removed. And we were able to do all of this and maintain the contour of the face. And we were able to go into the hip, take some even stem cells from the hips, basically some bone marrow aspirate. And we were able to execute a plan for him on the last mission when we were in Lebanon. And the next one, when we go, was we're going to give him a couple of dental implants for him to be able to get some dental prostheses on the right side. So here on the bottom, we were able to see him at pre-op, and we're able to see him in 1 year post-op. And he, you know, every couple of months, he sends me a picture or video of how he's doing. And it's great to be able to see an outcome, because if we didn't, that mandible is going to have a pathologic fracture, and I'm not sure how will that be handled for our, you know, refugees. What would they do? I don't know the answer to that. But I'm glad we had the opportunity with all the collaboration to basically get him to end result. This is a patient that had a cleft lip and palate that was repaired, but now they're at age 10 where they need the bone put in to allow the orthodontist to align the teeth correctly. But regardless, you know, we're able to assess based on the VR, where's the defect, how much bone do we need, and we're able to do this in, you know, an hour and a half, 2 hours in the OR and bring him to completion. The challenge for him later on is going to be when he's 15 and 16, because of all the scarring of the palate and the lip and the surgeries and the revisions, his upper jaw is going to completely be underdeveloped. He is going to need one of these Laforts probably when he's 17 or 18, and hopefully we'll still be able to provide that service for him later on. So here's a case that we did last May. This is a patient that we identified into the database, and we recognize that she has a significant facial asymmetry. And one of the reasons that she had a condylar hyperplasia. It's a benign entity of the condylar head of the face, of the mandible, where it's overgrown. And as a result, her entire face and jaw is going to be crooked to one side. So we identified this. This is one of the first total joint cases that we were able to do in Lebanon. You know, surprisingly, and how beautiful it was that we were able to partner with one of the local oral surgeons there, who was a family member, was a parent of one of the SAMS volunteers from Lebanon. And he came in, shadowed us. He was wonderful because he's never done any of these cases before. He partnered with us. We were able to work with him. And he was our asset to go to understand the need and the utilization opportunities within the country and what can be done, what cannot be done. And he was our exit in case we had complications. And he's the one that removed the plate that was exposed last week. And he volunteered his time for us. So having assets in the host country is going to be vital to allow us to execute these level of complex cases. So this is a case that we identified. We performed the surgery in VR in a matter of a couple of minutes. So we removed the condylar head. We aligned the jaw. We're able to determine from VR what size, what type of joint we need for this person. And there's a whole selection. And these are pre-stock, they're not custom. Custom is very challenging to obtain. And even custom is very challenging to get in the US and extremely expensive. So Biomed was able to give us a stock of joints. We selected which ones we wanted to fit. We knew the size. We knew everything we needed. We knew the plates that we needed. And we were able to get all of these donated that we took with us on our mission. Some of them we had to buy. And we were able to execute a surgery of this level of complexity in a matter of 4 or 5 hours in Lebanon. And we had all this thing planned before we got there. So the beauty and the advantage of being able to perform these ahead of time is just what gives us the opportunity. So I feel in my mind that, you know, the role of virtual reality certainly improves patient outcome, reduces hospital stay, reduces surgical costs, because OR in the US is estimated to be around, I think, 120 a minute. So it's significant and it adds. And we're able to take complicated level of surgeries and be able to perform them on missions that are a week to 2 weeks long. And only if we have in-host country support. Otherwise, I think they're drastically challenging. But that's what makes SAMS unique and special. So, and there's plenty of studies to support the role of virtual reality, surgical and procedural training, 92% more accurate because you can keep repeating doing the surgery, and such a great tool to be able to use for, you know, M&Ms, for example, and board review styles, and say, here's the tumor. How would you want to walk me through it? Walk me through the complexities. Walk me through the complications. What if this happened when you're performing, and I can, you know, cause an unintended fracture or an unintended complication? Let's rehearse this. I think there's a tremendous value in education. Where I see the future is to integrate augmented reality, and I'll show you a prototype that we started, but also integrate AI into it, right? So, and I'll explain that here in a second. So this is a prototype case that we did about 5 months ago. This is using the HoloLens. So here I'm in the OR. We're doing a resection of a mandible. We're doing actually an orthognathic case, a part resection, part repositioning. And on the screen behind me, in front of me, you're able to see what I am seeing, but you're not seeing the transparent component. So I'm able to see this mandible overlaid on the patient. I'm able to see the skull. I'm able to see the teeth. I'm able to see everything overlaid. But this is not tracked yet. It will. Give it about a year. So it's able to keep track of the dimension geometrically from three-dimensional space. We're not there. That will come in a few years. But one of the other things that can give me, if I am selecting a screw size, or I'm putting for a tumor, if I'm resecting my mandible, AI can tell me, well, you're outside the normal parameters, or we know this is an aggressive tumor. You need to correct and go, you know, a couple of millimeters outside. So this is where I think augmented mixed reality with AI integration can really play a vital role in tomorrow. And I see that coming in the next couple of years. And obviously the benefits are huge, but being able to integrate these into our missions, I think there's a tremendous value and a tremendous opportunity to take complicated surgeries and be able to perform them in our missions. And I think there's a role for that, and we've proven it, and I think we can take it to the next level slowly, as long as we have support on the ground in our host countries. And with that, I'll open up for questions or comments.
Wow, Dr. Joseph, thank you so much. The more I listen to you, the more I'm amazed by all the work that you've done for your patients, for the patients in Lebanon, and you also prepared the cases sometimes for Jordan, and it's amazing. I'm very, very excited for the future of oral maxillofacial surgeries for our patients in SAMS under your leadership. I'm very, very thankful. So we'll open it with questions.
So they're taking this technology and they're applying it for neurosurgery. So somebody has a neural tumor, and the Mayo Clinic invested a significant amount of money, so did the Cleveland Clinic, the neurosurgery department, to be able to do tracked version. So now the augmented reality mixed reality in this case, is able to see the tumor of a skull inside the skull, and they can project what's going to be the best optimal approach based on patients, neural scans, the MRI and the CT overlay. So that's where AI can come in very favorable, and that's in its infancy, but it's coming.
Thank you very much, Dr. Joseph, for this very interesting and vision of the future surgery. I'm an ophthalmologist and a retina surgeon, and in the last 5 years, the same techniques for doing virtual reality surgery has also come into the retina field. Unfortunately, like myself, as an old-timer, the roads to be able to master those techniques is a little bit steep, though all of the retina surgeons right now, the ones that are in training, are actually required to do that. So most of our surgery historically have been through a microscope. We sit in front of a microscope and the patient head is under us, and we kind of the ergonomics of how to manipulate the surgery we are used to. Nowadays, there's a new system called Ingenuity, in which the surgeon will put on the device that you would have, and they would look into a big screen, and they're actually not looking through a microscope. They're just looking through the goggles that they're doing, and then sitting at the head of the patient and doing all the surgery, and are able to do that. So it is the future, and as the comment said, I wish I could go back and learn some of those techniques, but whatever you showed us just gave us a vision of what future virtual reality surgery is. Thank you very much.
Of course. Thanks for sharing your insight.
We do have a question in the chat. It says, can surgeons use AI to do surgeries in the future far away from the patient, like away from the team on the ground?
I think to answer that, if you want my honest answer, I think it's a no. I think there is an intuition component in surgery that I don't think can be taught. And the only way you're going to get it is through practice. And I'm not sure AI can figure that. AI can figure out a lot of the question, be intuitive in answering questions, but to execute, there's a tactile component in surgery for the ones that really do it, and they do it very well, that I don't think can be modeled. So I don't think the answer to that. I think it can tell me where I need to do the cut. I think it can do a lot of the planning for me without me having to think. But the question becomes, will patient trust it? I don't know. Would you want to have surgery done? Would you want to have a filling done by an AI without a human interaction? It's tough. But what I do see in complicated surgeries, the role of mixed reality can really play a role in, for example, a place in Africa that has a massive brain tumor that is so unique and so aggressive, and there are no means for them to come here. The surgeon can have a headset on with another expert here, and they can collaborate and rehearse the surgery in VR or in AR or in real life, and be there to walk them through it as another set of eyes. And there's work that's done on this, kind of a shared VR or shared AR, that's coming. I'll give it a couple of years, but AI completely operating remotely abroad, I don't see it yet. 10 years from now, maybe. I don't know.
I do have a question myself. From your experience, I know you've done these surgeries here in the United States, but then you went to Lebanon and you've done them there. What kind of challenges you've noticed in the Middle East? I mean, in the cases, in the areas that we work in for our refugee, what kind of, I bet that there are challenges that are common across the whole board, but what do you see us able to expand on this, do more of these in refugee areas where we serve with Jordan and in Lebanon?
I did face a significant amount of a shift in the way people think and looked. I think initially at the beginning, they felt that, at least that was my sense, and my Arabic was broken, but I mean, I can understand and communicate, but the medical terms I needed help with. What I felt that it took a little bit of time when we met with these patients earlier on during our first day, They felt that we're there to operate because we want the experience. And I think it took us a little bit of time to understand it. And when the trust was built and they knew there is an infrastructure that we're there to help them and we're there to walk them through it, and they can get a hold of us immediately at any moment in time when they need help or there was a complication, I think significant amount of the trust was gained, which made and allowed us to open a door for a credible reputation that SAMS is there to help and is not there just to practice. But it's critical that we want surgeons to participate and take on these challenges that are in it for the right reasons, not to glorify themselves, but in it because they want to help the patient. And they're not there just to learn, because we're going to be cleaning up the complications, but they're there under clear intentions of noble intentions to really help and earn their trust. And we had a good number of surgeons that were committed, and we were able to be very productive. You know, we had issues. I'm not sure, some people must have heard. There were 2 chief residents that we kicked out on our mission. It was a difficult decision because they were, I teach them, but we've asked them to walk out and not be part of the mission because their intentions were completely wrong, and they made and executed decisions without supervision that was unacceptable to the mission and the team leaders that were there. So we asked them on the 3rd day to not participate and just be spectators. So we have to have a certain standard, at least to this level of complexities, and it's a lesson learned for all of us. Any other questions?
There is a question in the chat, and let me just see if somehow I got this connected. Can someone help me find the question in the chat?
Is
Here
there
you
only
go.
one computer and a server, a medical VR?
Yeah.
Are they commercially available?
Yes.
And what will be the pricing? So
Yes.
the company we
Thank you.
use, the company that I use is called Immersive Touch. I've been one of their board advisors for the past 5-6 years. And during COVID, we sat down every single Friday for 2 hours with their engineers to optimize and perfect the system. There was 10 of us, surgeons primarily, from orthopedic, from neuro, from ophthalmology, and we shared what we wanted in the system, and they executed it. So it is available. It is commercial. Everything that I showed you, you can go in and use it. They have a licensing. It's a monthly subscription. For institution, I think it's about $20,000 or $30,000 a year for unlimited access to data. They'll give you the headset, they give you a computer. So basically it rolls down to around $2,000 or $2,500 a month. And you take the CT scan data, you give it to the engineers. Within 24 to 36 hours, you will have the VR files made for you, which makes the colors, everything beautiful, and they can segment. And it's not only for head and neck, but it also can be for neurosurgery and so forth. But a lot of times, in my mind, I don't pay that fee, is we bundle it with the plating companies. So the plating company, for example, I use Biomet for my plating and joints. So they give me access to the laptop. They give me access to a VR headset, which the whole thing is probably $3,000 to $4,000. And you're able to manipulate and do all of these things. So it's commercially available. Immersivetouch.com. Or you can call me or text me. I'll be able to connect you with them. But it's out of Chicago, and a lot of our SAMS members I know are from Chicago, so it's a very close to home, and it certainly can be utilized. And all you need is a one laptop, one headset, and that's what I took with me to Lebanon, and we're able to do all these surgeries. As a matter of fact, on day 1, we revisited, we rehearsed every single surgery, and sometimes, the complicated one, we videotaped it and we showed it to the patient as we're doing our consult with them, so they knew we were prepared and they knew what they're getting themselves into, because we were able to do a VR consultation, which I refer to as a VR consent. How many patients really understand when you tell them, I'm going to take a tumor in the brain, I'm going to take a tumor out of the face? They truly understand what's going on. most of them just initial. Here, they're able to visualize what they have and understand the complexity, which minimizes, medical legal liability in our mind. And it's very, very powerful component to engage the patient. I think we went way over time.
I think we're getting, but this is a wonderful, wonderful talk. I really appreciate it, Dr. Joseph. I appreciate that also a lot of our leaders were on this lecture, so we can maybe move towards more of these services for our patients who are in desperate need for it.
Desperate need for it. And there's a tremendous need. We just need the situation to get more stable so we really can engage.
Yes, yes. Well, thank you, Dr. Joseph. I appreciate you guys. Thank you.
Thank you, Dr. Joseph. Thank you so much.
Thank you, everybody. And thanks for inviting me.
Have a good evening.
And you guys have a wonderful evening. Bye-bye.
Bye-bye. Thank you.